for you to view. We have a YouTube channel called Retinoblastoma Research and a Spotify channel called Retinoblastoma Research. Our previous cup of tea is not ready yet from March, but all the previous ones are. The March one will be coming this summer. So for today's presentation, I'm going to go through some announcements. I will share an introduction to our cup of tea, and we will go into our article summary, which will be followed by our community discussion. And we'll have some questions for you to think about and start our discussion with. I wanted to first share that I see most people here already are very familiar with our Retinoblastoma Research Advisory Board and our Retinoblastoma Research community. I just want to remind all of you here, as many times as I have already, to please share information about our community to new families, maybe to older families who might not have been active for a while. And then any families that are here, share with others that you know who would benefit from being part of this community. So the way that you could share information is through inviting people to events such as this one, sharing posts from our social medias, and inviting them to join the Retinoblastoma research community with the links shared in the chat. We have our website also. You could go through the website to join as well. It's rbcanadaresearch.com. And reiterating again, the YouTube and Spotify channel is Retinoblastoma Research, where you can watch past videos, not just of the cup of teas, but other events that we had recorded and have available for you. We have some opportunities for members of our community to partner in research. We have upcoming cup of tea events, which we're seeking partners for. So our next cup of tea will be in September. The theme will be biobank. And then our December theme will be new treatments. And how the process works is we have a theme, and together with our patient partner, and of course with help of Helen Damaris, to narrow down articles that are appropriate for the topic and are relevant to share with our community. So we don't have an article. The article is chosen with our patient partner, and then we choose our non-patient partner to work together with us on creating the summary and the presentation. And I can share more information about the process. Anyone who's interested, you could email retinoblastoma.research@sickkids.ca if you would like more information, and you'll be connected with me. I also wanted to share about the Rare Pediatric Eye Cancer Biobank, or RPEC Biobank. They have a patient advocate committee which meets monthly to work on biobank items. So it's a really great hands-on experience. Welcome to anyone from the retinoblastoma community. Also, if you would like more information, to email retinoblastoma.research@sickkids.ca. Upcoming events, I mentioned the September and December cup of teas. There's also the ongoing OPAC parent drop-ins happening Monday, Wednesdays, and Fridays at 10:30 at the Sears Cancer Clinic on the 8th floor of SickKids. If there are any other events happening at other hospitals that are benefit to our retinoblastoma community, please let me know. I'd like to include them in our announcements board going forward. So today's cup of tea, the article that we'll be discussing is Intra-arterial chemotherapy for unilateral advanced intraocular retinoblastoma, a long-term review of a case series. The plain language summary of the article is available on our website, rbcanadaresearch.com, if you want to see that and share it with anyone. Our guest speakers today are Peninah Li, who is a mom to an RB patient who received treatment in Vancouver and was introduced to the retinoblastoma community by Dr. Payton. Peninah has been attending many of the cup of tea events and other activities hosted by the Canadian Retinoblastoma Research Advisory Board, and has taken on this challenge, and we are very happy to have her here with us. Our non-patient partner is Prakash Muthusami. He's an interventional neuroradiologist at SickKids Hospital who diagnoses and treats neurological conditions affecting the brain, head, neck, and spine. And among many achievements he's accomplished at SickKids, he's also pioneered Canada's largest intra-arterial chemotherapy for retinoblastoma. So Peninah, if you're ready, I would like to pass it over to you.
Hello. I I laugh when I'm nervous, so bear with me. So as mentioned, the article we're talking about is the intra-arterial chemotherapy for unilateral advanced intraocular retinoblastoma, the tongue twister, a long-term review of the case series. My personal story is Olivia was diagnosed at 2.5 years old in August 2022 following an optician's visit. She had no visible symptoms or complaints, so the diagnosis of anything being wrong was quite a shock to us. The optician's visit was just a random. My mum's always said you go to the doctor, you go to the opticians, you go to the dentist. So I just took my kids along, and they noticed something was different with Olivia. I didn't think anything of it, and then we were referred to a specialist, and then we got referred to Dr. Payton. Her left eye was enucleated and was followed by 6 rounds of chemo due to the tumour showing signs of microspreading in the optic nerve. And she's now 5.5, and as you can see by the cheeky face, she's doing just great. What struck me with this article was learning and understanding of different approaches to RB treatment. Some key terms that have come up in the article. So we have, and I tried to practice it, but I've forgotten already. Leukorrhea. I'm sorry. It's an abnormal reflection of light in the pupil that appears white, can be noticeable in photos taken with a flash. And then we have the strabismus, the eyes that appear misaligned or eyes that don't move together, also known as cross eyes. More key terms, the International Intraocular Retinoblastoma Classification, the IIRC, is one of the main classifications and stagings for retinoblastoma, which group tumours from A to E while considering their size, location, the presence of seeds, small groupings of cancerous cells, and retinal detachment. So you have a grade A, as you can see by the picture. So small tumour is 3 millimeters or smaller, away from the optic nerve and foveolar, so no seeding. Grade B is a tumour any sizes, no seeding, no more than 5 millimeters of fluid buildup under the retina. A grade C tumour is any size, local, fine and easily treatable seeding, may have some fluid buildup. A grade D, large tumours with no clear edges growing deep into the eye, extensive seeding, or a large area of the retina is detached. A grade E tumour is either physically damaged beyond repair or has lost all ability to function normally. High pressure in the eye, lots of bleeding in the eye, swelling in the eye socket, tumour growing close to or touching the front of the eye. An overview. The background. Overview of retinoblastoma, RB. RB is the most common eye cancer in children. It's typically diagnosed before the age of 5. It can affect one or both eyes. Current treatment options. Intra-arterial chemotherapy, IAC, is a key treatment to preserve the eye and maintain vision in children with advanced unilateral RB. Compared to traditional treatments, e.g., intravenous chemotherapy, IAC has shown better eye preservation rates and fewer side effects. The purpose of the study was to evaluate the long-term efficacy and safety of IAC in children with advanced unilateral RB. The method, the study design retrospective review of patients who received IAC at a single center between 2016 and September 2019. There were 39 children in the study with unilateral advanced intraocular RB who achieved short-term globe salvage. and the mean age of treatment was 1.84 years old. That's all on that one. And so the data collected, the methods used in the study, they used demographics, tumor stage, prior treatments, IAC course, complications, looked at the long-term outcomes assessed through online questionnaires. The IAC procedure is administered through the femoral artery puncture and catheterization of the ophthalmic artery. Very long word. Using chemotherapeutic drugs like melphalan, topotecan, and carboplatin, and following up with the data analyzed for up to 5 years. The global salvage rate for this study was 87.18 of patients maintained stable eye preservation after 5 years. Some of the side effects noted: short term, considered mild, nausea, vomiting, eyelid edema, and virtuous hemorrhage in some patients, droopy eyelid, puffiness around the eyes, and reddening of the skin. Some long term, more serious side effects was cataracts, the most common complication, and other complications: slowed eye growth, damage to the optic nerve, retinal detachment, worsening of vision, and misaligned eyes. The results of the study was 3 patients experienced tumor relapse and 2 opted for enucleation due to severe complications. The conclusions of the study shows that IAC is an excellent long-term effectiveness for eye preservation in RB patients with acceptable risks, though long-term side effects need close monitoring. The limitations of this study: it was conducted at a single center with a small number of participants. There were 39 children, which limits how widely the results can be applied to other settings or populations. It is a retrospective study relying on existing medical records and follow up through voluntary online questionnaire, which may have introduced selection bias. Not all eligible patients, not all eligible patients chose to participate in the follow-up. The research noted the need for larger multi-center studies to confirm their findings and better understand long-term outcomes and the risk factors associated with IAC. The study mentions globe salvage, but has no comments on vision as outcomes. A summary of the key findings from the study was: IAC is highly effective for preserving the eye in children with advanced unilateral RB. Long-term follow-up is critical to manage potential complications like cataracts and growth arrest. Future directions: more multi-center studies with large control to comfort findings and assess long-term risks. Investigation and ways to reduce complication and personalized treatments for better outcomes. And that leads me on to asking, do these findings align with what you know and see in practice? Sorry, I've lost my paper. Prakash. Sorry.
Sorry, hi. I thought I'd just talk a little bit about how this one goes along with the data we know in the literature, but also with our own experience. So I think one of the things we noticed in this is that while it does talk about globe salvage, I think it's also important and I think Ashwin, you should talk a little bit more about that as well, and Brenda. But when this study in particular spoke about groups D and E, and especially when we are going into group E, I think it's important to also evaluate what sort of visual salvage we have when we talk about globe salvage, and so the literature is quite consistent. For example, if you look at this is 10 years of experience from the Lausanne group in Switzerland, and they did see when you use IAC as your first line of therapy for retinoblastoma, you have a lower rate of, and this was data without intravitreal chemotherapy, so it's just intravenous and intra-arterial. So the recurrence rate was what they found was much lower, and at 2 years they found that they were able to salvage a large number of these globes, and overall they said that there's about a 3.7 or 3.8 times that they found over this period of time when they've been doing IAC, that their rates of enucleation has reduced, and you can see that chart there from about 2006 to 2014. Slide. And these are two different studies. So there's the one on the left, and then there's the one on the right. The one on the left, I just put that to show the relapse rates when especially when, and the one on the left is from the Munier group. It came about in 2017. It focused on looking at relapse rates when intravenous and intraarterial chemotherapy was used in addition to intravitreal chemotherapy. And some of the things that they looked at was sort of the quality rather than the standard outcomes that we look at. So they looked at things like what's the duration that's taken to the end of therapy, and that's what this chart shows. The difference between IAC and intravenous to reach the end of therapy was much lower, and then the number of anesthesia events that are required because of various reasons, the number of emergency visits that are needed between intra-arterial and intravenous. And so they looked at a number of different measures, which are also, I think, are interesting to discuss. Of course, there are also practice patterns um, which direct these kind of things. So it's not one size fits all. The study on the right, I just put it there to sort of show a more reasonable, I think, table of globe salvage. So when we look at globe salvage, you do expect a slight increase of globe salvage in the group B and group C, where you already have a good globe salvage with the intravenous chemotherapy group, but the real gain is in the group D population, where you have almost in most studies you'll see like a 40 to 50% sort of globe salvage rate in group D, and I'd say between 60 to 80% globe salvage rate in intra-arterial, and then it drops again with the group E's. Again, because of several reasons, it's also a lot of it is driven by, is there visual potential of that eye, and is it actually safe and reasonable to retain that eye, and so many other factors which come into bearing. I think one of the important things is metastasis. It's always been hard to gauge that. So it's always been hard to assess that. The big question is, how long do you have to assess this to be able to confidently say that, okay, now we are sort of happy to say that that risk is no longer there. All right. Slide. I just put this to show the anatomy of what we do. So I'm an interventional neuroradiologist. I work at SickKids, and I do these procedures. I've been, you know, the group of us got together in around the end of 2015. So this is actually 10 years of us doing intra-arterial chemotherapy now. And some of us who started it are on this call, I can see. But I put this to show the anatomy of what we deal with. You know, a lot of the pictures and the cartoons you see will show you that sort of a tube and then a catheter going into the tube. But in practice, it's much more involved. You know, you have tortuous anatomy in little babies. You have the carotid. So the picture on your left shows you the carotid artery which goes into the brain. It's the artery that actually supplies blood into our brains. And en route to that, it gives that artery which I've marked in red over here, which is the ophthalmic artery, and that's the artery that we get into with very tiny microcatheters. These are almost hair-like catheters that we navigate into these arteries in order to obviously deliver the drug, but also at the same time be very gentle and not damage them. The picture on the right is actually showing an injection of a dye. Before we actually inject the chemotherapy, this dye shows us that we are in the right place. This is actually the entire anatomy of the ophthalmic artery that you're seeing there. The arrow there points to the artery of the retina specifically. The curved structure you see on the right of that image is actually the globe of the eye. So that's it's a very vascular structure. There's a lot of blood flow into it, and so you're actually seeing the dye filling all of that. And this is sort of our determinant that we are in the right position. And at this point, we would start injecting the chemotherapy. Slide. I just put this this is sort of a little bit to show the other things which we also have to think about. I think we focus a lot on the tumor itself and the retinoblastoma and the anatomy I showed you and the vessel. But when we do a procedure like this, I think it's also important to note that there are a lot of things that go into a procedure like this. There's a whole team involved. There's the anesthesiologist, there are the technologists who help me. There are, it's a whole decision-making progress that starts with the ophthalmology team, the oncology team. But even in the procedure itself, there are so many things that we have to consider when we work in these tiny arteries of these tiny babies. We also have to consider things like protecting blood flow into the brain, into the eyes, the amount of radiation that we give, uh, the fluid volume, the temperature of the baby. There are so many things that are actually happening at a simultaneous level. And so I just put this slide to sort of bring a larger perspective into the IAC, and also explain to an extent why this procedure is not offered in many places, because you do need a very high level of a team set up in order to be able to do this procedure in a safe and effective manner. And it's not something that you can just do once in a while and get away with, because that's really not how this procedure can be effective or safe. Right, slide. Right, and this was just a video that shows. I think if you click on that link, it takes you to a YouTube video which shows how we do this procedure of an IAC. And this is just a 1 minute sort of video, so it's fairly quick, but it shows how that catheter has gone in from the artery on the leg, that's called the femoral artery, and then goes up the highway. And then it's now in the carotid artery. That's the artery which I showed you also in that picture. That's the artery that actually supplies our brain. And then you can see through the tube, the catheter, goes a smaller tube, a microcatheter, right there. And this microcatheter is now going to go into this artery, the ophthalmic artery. This is the artery that supplies the eye and therefore also the RB tumor. So there the microcatheter has now, these are very, very small catheters, as you can imagine, and that's superimposing the anatomy of the blood vessels of the eye into which then the chemotherapies are instilled. So that actually the blue color there is showing how chemotherapy is going into the artery. And then you can see also that this artery is supplying the tumor, but it also supplies, on the way to the tumor, it supplies every part of the eye and everything around it, the muscles of the eye, the skin, the hair. And so some of the side effects that we see after IAC are actually related to the fact that all the arteries in this, just like when you have intravenous chemotherapy, you have chemotherapy going to all parts of the body. Here you have chemotherapy going to all parts of the eye, and so some of the local side effects are related to that. All right, back to you, Ivana.
Okay, thank you for that explanation. I think it was very helpful to see the little video. I think I had the volume on, so I'm sorry if the volume of the video was interrupting with Prakash's explanation of that. So I wanted to now open up our community discussion. There was a really great information shared. Peninah read the article that she was interested in about what are some of the options or treatments that are happening in retinoblastoma, and specifically wanting to know about long-term side effects. This was a topic that was selected by our patient partners during our symposium. It's a very important item to know because these treatments are being used, and we just want to make sure we understand the side effects and how the long-term results are. So I wanted to open up the floor to anyone who has questions. I've listed some on the screen to get us started. If anybody has any questions about the article or about Prakash's presentation or about IAC. While maybe you're thinking about it and reading these questions, I was really curious. We want to know long-term side effects, and we want new treatments, and we want treatments to move forward with retinoblastoma. I wanted to ask clinicians, if somebody can answer this, how do you evaluate treatments when they're new to know that they're safe and they're working without having to wait 10 years to find out what long-term side effects are? How do you balance that when you're treating a patient?
Yeah, I think Brenda's opened her mic, so I'll just say one little thing. I think that's sort of the holy grail of medicine, isn't it? It's like I said before, vaccines, everything that you sort of have to figure out risk and benefit for. With IAC, I think there's sort of a duality in terms of what we had in terms of literature. IAC in itself was something that was done to some extent from the 80s, and then 2010 was when larger groups started doing it. And so we did have some data before we started doing it. In other cases, there are trials, there are animal trials and things like that which are done. IAC itself did not go through a very robust randomized clinical trial, which is the sort of the highest level of evidence for in medicine. And a lot of evidence that we gathered was through experience and data. And I think one of the things, when I say the duality, the second part of it is there's always the question of is there something in 20 years, 25 years, 30 years that we don't know that sort of tilts that benefit risk ratio?
It was a little bit hard to hear what Dr. Gallia had to say, but I'm going to relay her message so that everybody can hear it clearly. Her message is as follows. Intra-arterial chemotherapy was preceded by external beam radiation in the 1960s and was primarily done in Boston, New York, and London. It started with no clinical trial and no data collection. It took until the mid-1980s to realize that 50% of the people who had external beam radiation to save their eye died of second cancers. Lack of record keeping and clinical trials resulted in these patients having severe side effects. I don't think intra-arterial chemotherapy has the possibility to be that severe, but it did go global without clinical trial data or accurate full follow-up data. There's also need to compare the doses and drugs and fully report complications and good and bad outcomes.
There are some questions in the chat.
I can take the one on radiation, and I think Ashwin had unmuted at some point, so I'll just say something about the radiation. When we do these IAC procedures, we've worked over the years very closely with our physicists to work on radiation levels. As a default, our default radiation doses for children, for pediatric cases, are already about a third or less than what we'd use in adult patients. And then when we do IACs, we are even more cognizant of that, and we drop it even more. So actually, in the spectrum of cases that I do, if you look at all the sort of cases that we do, the IAC actually comes on the lowest end of the spectrum of radiation that we are providing for, that we are using for these cases. We've published some data on our radiation doses as well over the years, including on IAC. And none of it actually comes within even close to sort of ranges that our physicists would start worrying about, either deterministic or stochastic kind of changes that we know over the years through the literature about radiation changes. Um, but this is definitely something that's interesting for us to follow over long term. Most children have 2, 3, or 4 procedures. There are few who have 4, 5, 6 procedures, and that would be something that it's not a lot, so we are not going to have a large number, but it's something that my gut is that the radiation we use is so minuscule. It's very close to, say, what you'd get with a chest X-ray, and probably less than what you'd get with a long distance flight, New York to Tokyo kind of flight, and so um, that's sort of how we work on it.
Was that any further questions about that, Charles?
No, that's perfect. I mean, it's always the question what all the RB parents have, right? And it's seemingly, especially with my case and Caitlin and secondary cancer, has had more X-rays and CTs and all that kind of stuff than anyone I know. But I suppose that the risk is certainly outweighs the long term.
Yeah, that's true. It does. And then the dose of an IAC compared to a CT is very, very small. I'd say it's like less than 5% of a CT.
Thanks, Doc.
Another question was asking if there are publications comparing vision outcomes in addition to globe salvage, or if anybody could speak about that from their experience.
Maybe Ashwin, you want to take that?
Yeah, I can take that. So there are efforts to talk about vision salvage and the difference between intra-arterial chemo and the other modalities that are available. However, there isn't anything that's conclusive that's out there that I know. Part of that problem is that vision is mostly affected by the location of tumor. And the location of tumor is not something that changes between treatment modalities. Therefore, even things like globe salvage or eyeballs, saving the eyeball itself, and life salvage are talked about, but vision salvage is harder to talk about. There are some studies that talk about these surrogate measures, such as impact on the retinal photoreceptors. So they use a specific test that's called an ERG, or an electroretinogram, which is kind of like a cardiac ECG, but it's for the eye. And when you shine a light into the eye, it's the electrical response of the photoreceptors of the eye. And we do know that that is affected by IAC. Now, whether it's affected the same or not with systemic chemotherapy is something that we also don't know. So these are the kinds of gaps in knowledge that exist. However, a meaningful difference in vision between systemic chemotherapy and intra-arterial chemotherapy, I think, will lie in the complications that we notice with each of these modalities. Intra-arterial chemotherapy is an excellent modality at addressing the tumor, but almost as a collateral damage, it also shuts down some blood vessels very rarely. And sometimes those blood vessels could be supplying parts of the retina that are visually important. And those things are things that we're learning about a lot more. We know that, and I'm just quoting this off the top of my head, so this may be an inaccurate statistic, but we know that about 7% of those cases that undergo IAC will have evidence of these vascular shutdowns in the eyeball. And I think that we should keep those sorts of statistics in mind, but also obviously we're treating an aggressive cancer, and a treatment like intra-arterial chemotherapy is certainly what we now know as a game changer. But I just want to say that there can never be an absolute solution, or we find that there is very rarely an absolute solution. Nothing can be all good and not cause side effects at all, and nothing can be the other way around, all bad and cause only side effects, because those things don't survive the vetting process that the medical community now has. The best of the vetting process is these randomized controlled trials. But I do think that there are limitations to that in these rare cancers where we will not have that kind of evidence. And there are ways to overcome those limitations, but each of those ways to overcome limitations also have their own limitations. So we could go around in circles there. And about long-term side effects, I just wanted to say that some of these side effects you wouldn't know until we really have patients surviving for that long. Even with external beam radiation, I think the after effects of radiation was known years after the success of radiation was. But I think similarly, with other modalities, with chemotherapy, we knew a lot more because it was the same chemotherapy we were giving for other diseases. But with these things that we do specifically for the eye and retinoblastoma, I think it'll take a lot longer for us to know proper long-term data. One of the things that piqued our curiosity early on, and I know that Brenda was a very vocal advocate in this way, about case stories that would come out of relatively poor outcome with intra-arterial chemotherapy in patients who've sought the treatment or who've been offered the treatment in a way to not enucleate an eye. I think the sentiment of trying to save an eyeball above everything else, including the life of a child, is something that came to the forefront when that argument was being brought forward now 15, 20 years ago, maybe. And I think those arguments have brought out a more healthy and a more, I would say, a more measured understanding of what intra-arterial chemotherapy can and cannot do. So, for example, some of the earliest publications would say 100% survival or no all globes salvaged with Group E disease, and those can't be true in a statistical sense as well. And as Prakash had mentioned somewhere, there is a situation where some of these tumors can be life-threatening or in life-threatening situations where you don't want to salvage the eye. And choosing those tumors that you could or may not be may not be ideal for IAC is something that is that only happens over time. And I guess we're now in a more mature state compared to 20 years ago. So I hope that answers a few more questions on the list. And if anyone has any other questions that have stemmed from this, I'm happy to respond.
Can you hear me now? Am I any better now? No?
Yes. Yeah. I think it may be that your computer is connected to a Bluetooth microphone that's further away. If you want to turn off a Bluetooth and your
Bluetooth microphone, no.
Okay.
No, I think you just have to be close to the computer itself.
That's pretty weird. Okay. Anyway, I just wanted to say
can I open a certain discussion that I've been asked a couple of times about bilateral IAC in the same session? So what do you think about that? And is it now a valid option?
I'm not sure who you're addressing that question to, Sammy. Is it perhaps Prakash?
No, it's for the whole group. It's for the brainstorming, because I've been in a conference in Jordan, and I met a couple of people, and they are now thinking of doing the bilateral IAC. Yaqub is still against, but many are discussing doing it in the same session instead of systemic chemotherapy in certain patients, especially the ones that like the maybe 1C, 1D, a good D, thinking of doing it instead of systemic chemo. And they were discussing, so I want to hear our experts like you, Brenda, Prakash, what do you think about the technicality of it, the technical part, and the actual practical part of it?
So I'll just say one thing about the technical part, and then Brenda, Ashwin, you can continue. From a technical point of view, the procedure is quite straightforward. It's sequential, so we go from one side to the other. The amount of radiation, contrast, fluid, and anesthetic or time increase is minimal. It's not 2x because we're doing two sides. It's actually much less than doing it twice. My only concern would be from what Ashwin had said before, and the problem of choroidal or retinal vascular damage. Even if it's a small percentage, say I think it's somewhere between 5 and 10%. My worry would be to offer that to someone who has one good seeing eye. So that's sort of my more sort of technical answer to that.
Risk of serious damage to vision in both eyes is not zero, and so maybe when that was even considered, it would need to be very clearly presented to the parents what the risks are of doing both eyes at the same time. We have done, I think, one trial like that for Prakash. Did we do one trial with both eyes?
Yeah, we have one child with bilateral IAC, and one more where we
two actually, isn't it?
Yeah, maybe two is what I'm thinking.
Yeah, we've done two.
But they were done slightly differently. I think one of them was tandem, and the other one was.
So in the other one, we split the chemotherapy. So we do 3 chemotherapy drugs. We did one on the one side and 2 on the other. It was also, I think, in a relapse, not primary IAC. It was relapse. And so we wanted that eye to receive melphalan, so we gave melphalan to one eye and the other 2 to the other eye, so that the total dose would not be too high. So there are some nuances that we changed for those procedures.
Yeah, but I guess Sammy's question is about primary bilateral IAC. And in that front, I agree with both Prakash and Brenda about, when there are these chances of choroidal vascular shutdown, then do you truly want to take that 7% risk versus the other risk, which is systemic chemotherapy? Now, there are situations where you might want to take that risk. For example, children who don't tolerate etoposide, children who have significant hearing loss in some way already from chemotherapy that they've received. But no, we're thinking of primary situations, so maybe less of the second one I mentioned. But there may be situations, and I will never say that you should not do bilateral. However, there may be situations where you'd want to do it. It'd be interesting to know if people are doing what their rationale is, and do they want to get rid of systemic complications with systemic chemotherapy, or do they want the globe salvage rates that IAC can bring, which systemic chemotherapy hadn't brought in those days? I'm not sure what they want out of that in Jordan. So,
so Ashwin, I've spoken.
So they don't want it in Jordan. The invited speakers were the ones speaking about this. So I agree with all of you. That's exactly what I said. That I don't want to put them under the loss of vision and the probability of the loss of systemic coverage of any micrometastasis, and if there are any hidden high risk features. But there are the publications, especially on the ones that are speaking about bilateral, and the good results are driving people to think that this is better, especially with now more publications about IAC saving the unilaterals that were previously deemed for enucleation. So they are now thinking of doing it, and they are you will find some people now starting to speak about. I totally agree with all of you. This is not the best pathway now to go, and systemic chemotherapy still is the best for a bilateral patient.
Peninah has a very good question in the chat.
Yeah.
Are the chemotherapy drugs you give via IAC different than IVC, and why?
Yeah, I saw the question in the chat, and that seems to be a very interesting question. Yes, they are different. I'm just trying to find a better person to answer that question, just in case Furkan is online or any of the other oncologists are. And
Bruce?
Bruce Crooks is online. Yeah, if Bruce can maybe comment on the differences in chemotherapeutic agents with intra-arterial versus intravenous chemotherapy.
Oh, hi, sure. Really, the drugs are actually, you can give the three main drugs that you give through intravenous are carboplatin, etoposide, and vincristine. And the ones that you tend to give through intra-arterial chemotherapy are carboplatin, melphalan, and topotecan. Pretty much you can give all of those drugs intravenously. The significant advantage to intra-arterial is you give them in such minute doses that there is pretty much no systemic effect. So the side effects that you see with intravenous chemotherapy are almost minimal with intra-arterial, and the effects that you really see are local with the eyelid swelling and the retinal changes and things like that. Really, the only drug that you can't, I don't think we would ever give intra-arterially would be vincristine, and I don't think we'd give etoposide the other way. But you can give we can give any of the drugs intravenously. It's just which ones are very, very used. Originally, when it was intra-arterial, it was just melphalan. And that was the original one, but then we graduated to using 3 drugs, which gave better results. But it's what you use and which one gives you the better result and which one's the safest. Really is that.
But Bruce,
that's the difference.
Melphalan.
I'm sorry, I can't hear you, Brenda.
I'll type a message.
Okay.
Peninah, did that answer your question? Do you feel you have any more questions or follow-ups on that?
There was a follow-up in the chat inquiring about the chemoplaque versus intra-arterial chemotherapy. And I think the jury is still out there in which of the cases we would advocate for the chemoplaque and which of the cases we wouldn't. So I would be very careful in trying to compare them, because I think at this point we don't yet know much about the efficacy of the chemoplaque as much as we know about IAC at this point. So it's not really comparing apples to apples at this point. So I would say that the situations for these different forms of different methods of chemotherapy are different. For example, if you have an eye with significant activity in the vitreous or vitreous seeds, then we may choose intravitreal injections. But if you have treatment that, activity that's limited to the retina, then you may choose treatment modalities that will allow for will allow the transfer of those medications through the blood vessels, which is intra-arterial, intravenous, and the other modalities. I think the chemoplaque we're not yet sure entirely about the efficacy, and I think we should be careful to compare those at this point.
We do know that the chemoplaque is very effective, but we don't have very many patients treated with it compared to all the other treatments.
Yeah, and when we say very effective, we also know specific situations where the chemoplaque didn't work in some of the patients on the trial. Right. And in those situations, I think I think larger volume disease comes to mind for me. Large volume primary disease is something that I would not consider a chemoplaque for treatment at upfront. More consolidated disease and certainly small volume disease is something that comes to mind. But as I said, I think we'll only know when we've had more numbers of patients on that, and I think that's kind of it's not something that we can compare right now until the next level of trials determine what they determine.
I think this was a really fantastic discussion, and we've run out of time to continue discussing more. And I think this really opened the eyes, at least to some of the patient community, to some items that our clinical and research team have been thinking about and what's happening in the broader community. So thank you for educating us and bringing these topics to our attention, and for sharing the information so clearly. I do feel like I've walked away with some more knowledge and better understanding. So maybe I have Ashwin has raised hand. Maybe one last comment before we sign off for the evening.
I just wanted to leave everybody with a message of understanding what the Gardner hype curve is. And it's not exactly like the Gardner Expressway in Toronto. It's not as frequently clogged in the same way, but the Gardner hype curve is something that will talk to us about how people perceive treatments. And I think that's a good way to understand which phase of the curve we're on with different treatment modalities.
Thank you for that. I think maybe we'd like to learn a bit more about that. And there could be opportunity for another either cup of tea topic or at another.
I think there's a cup of tea topic that talks about new treatments. So I think that may fit well somewhere there. If we can talk about it more there, that would be interesting.
Yeah. Okay. I will connect with you later then about the next topic. But everyone, thank you for joining us. We had a great presentation. I want to thank Prakash and Peninah for sharing the information with us. So join us next time in September for our next cup of tea. And let me know if anybody's interested in being a partner on one of our future topics. Thank you very much.